This review is from your Understanding Pharmacology textbook by Workman, and we're going to look at Chapter 9, which is pain management and the different types of medications we can use to manage pain. So the first thing that we want to look at when we're administering any type of pain medication is, as nursing, we always start with assessment. And so we always want to assess our patient and find out where is their pain score. And so we can do that on a standard pain scale if they can verbalize where their pain is on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain imaginable. So you can ask them where they fall. If they're nonverbal, then you can use something like a FACES scale. Or if they're a child, you can use a child scale and try to determine where they are. And so we're going to assess that first, and then we're going to document that assessment. And so it's important to know with pain that pain is very subjective, which means that it is whatever the patient says it is. And so if a patient can verbalize their pain and they say it's a 10 out of 10, but then looking at them, you're like, they don't really look like they're in a 10 out of 10 pain, that is not up to you. And you will administer medication based on whatever they say. Also, for an assessment, you want to check their respiratory status. And so, especially if we're giving something like an opioid, that dramatically affects their respiratory status. And so, we would want to assess their breathing and what is their respiratory rate. And if we feel it's below 12, then we probably want to hold this medication and not give something like an opioid. Maybe we'll give an NSAID instead. Also, we want to assess their sedation level with opioids. So if they seem very lethargic, very sedated, or they're hard to awake, then we would not want to give them more opioids. Again, we might move to something like an NSAID instead. And so we want to also know if their pain is acute or is it chronic. So is this pain right now, where it's just bad today, or is it chronic, which means they have pain every day for a long amount of time? This determines how we treat it. But we also want a good set of vital signs too for a pain assessment. So what are the signs of acute pain? So usually there's some other physiologic change that is triggering a stress response in the patient. So most of the time when they're in pain, you're going to see an elevated heart rate or tachycardia. Maybe their blood pressure goes up and their respiratory rate will go up. Also, they may have some cool or clammy skin, sometimes a dry mouth, and they may be restless or unable to concentrate. So what do we want to do when we're trying to manage pain? What is important? And so first thing is we want to set some realistic goals. We can't assume that if a patient is at a 10 out of 10 acute pain, that we're going to give them medicine and they're going to go down to 0. We just really need to get it to an acceptable, manageable level for them. And even a person in chronic pain, like sometimes 0 is just not reasonable. And then we want to make sure that they are recovering. And so we want them to have pain relief that enables them to take care of themselves. So if they can't take a bath, if they can't walk, if they can't interact with other people because they're in so much pain, we want to get them back to their baseline of functioning and to a quality of life that they can manage and handle. And then we always want to monitor. So after we give a pain medication, we want to assess their pain again about 30 minutes later. If we're giving an IV medication, we can do more like 10 minutes later. But if we're giving them something by mouth, then about 30 minutes to an hour later, we want to reassess their pain and see if it was effective and document that finding. So with opioids, I've already mentioned a couple of things that we need to note, but when we give opioids, these are a really high risk medication, and we want to check some things. So, first, we need to understand that opioids are going to work by attaching or binding to a receptor. And so that's just kind of the mechanism of action of how they work. And so people can become tolerant, which means they're going to need higher and higher doses. So if they're taking these on a regular basis, maybe 10 milligram has worked, but then in a few weeks, maybe they're going to need 15 milligrams. They're going to need a higher dose. It just doesn't work as effectively as it used to. And also, these are highly addictive. And so we really don't want people to take these long term. We want them to take them in a small amount to get their pain manageable and then switch to something else. So if you have a surgery, you may take an opioid, for the first 48 hours, maybe the first week. And then after that, the doctors are not going to want to give you any more. They're going to want you to switch to something not as addictive, like an NSAID or maybe a muscle relaxant. We don't ever want to substitute one opioid for another without the doctor saying it's okay. And so, for example, a patient may be taking Norco, 5 milligrams of Norco, and you're like, oh, well, they ran out of their Norco, but I've got some Percocet from when I had surgery, and so I'm just going to give them that 5 milligrams of Percocet. Well, 5 milligrams of Norco and 5 milligrams of Percocet are not the same, first off. But also, if a doctor only gives them 10 pills, it's for a reason. We don't want to self-prescribe or change that. Always use medications as the doctor recommends. You also need to be aware that these are antagonists in some ways, and so their half-life or how long they work is shorter than an agonist. And so if you give more than one dose, it may be needed, or giving more than one dose may make the respiratory depression or the lack of breathing worse. And so if you give too much of an opioid, patients will just stop breathing. And so that's what I meant by when you assess them, a normal respiratory rate is between 12 and 20 breaths per minute. If it's below 12, then we don't want to give an opioid, because it's going to make it worse. We also need to know that some opioids are an extended release. And so we want to be careful. We don't want to open capsules. We don't want to crush them if they're extended release. So we want the patient to take the entire amount, swallow, not chew, and don't crush, because we can overdose them easily. For kids, for pediatrics, sometimes it's harder to assess a pain scale for a child, but we do have specific pain scales for children. So make sure that we use them, make sure that we are taking pain seriously in a child, and make sure that we are monitoring them. So opioids affect kids different, and so we want to make sure that we're doing an apnea monitor, which would indicate if they stopped breathing. And then a pulse oximeter would measure their SpO2 or their oxygenation in their blood. Especially with infants or small children, we always want to be monitoring them closely if they're getting an opioid. So another type of medication that's not an opioid is acetaminophen or Tylenol. So Tylenol is not an opioid, but it's also not an NSAID. And so it's kind of a unique medicine all by itself, but it's a popular medicine that we use all the time. But we can give too much Tylenol and it can be harmful in certain patients. And so the main thing is it can be toxic to the liver. And so if anybody has any liver problems, maybe they have hepatitis or cirrhosis of the liver, we don't want to give them Tylenol. Also, we have certain parameters. We can only give them so much Tylenol a day before it starts harming the liver. We want to be careful with interactions. Just because something is over the counter doesn't mean that it can be taken with anything. And so we really want to teach our patients to try to avoid alcohol and any other drugs that are harmful to the liver while they're taking their Tylenol. Also, pediatric dosing would be different. And so it comes in a liquid and it's usually weight-based. And so they need to make sure that a child is getting the correct dose. Because again, these children can have liver dysfunction if we overdose them on Tylenol. Also, be careful of certain medications that have Tylenol. For example, Norco has hydrocodone and Tylenol in it. And so you wouldn't want to give them Norco and then turn around and give them Tylenol, because then they're going to overdose on Tylenol. So being aware of each medication you're taking and what is contained in that medication. So then we have some migraine medications that would help with migraine pain. And these are ergotamines and triptans. And so with these medications, we want to be really careful because they can affect the heart. And so they can cause hypertension, high blood pressure. They can cause angina, which is chest pain. They can cause myocardial ischemia, and that is like death of the heart muscle. And they can cause stroke. So we want to closely monitor our patients for any signs of these things, and maybe not give them if they already have high blood pressure or hypertension. And so these will cause the arteries to constrict. And so if people already have an atherosclerosis buildup or anything else that's constricting their arteries, we would want to be cautious with these. We also have another class that's skeletal muscle relaxants. Know that just like opioids, these are CNS depressants, and CNS is your central nervous system. And so when something is a CNS depressant, they can cause drowsiness, sedation, and these things are going to be worsened by things like alcohol, marijuana, or other medications that are CNS depressants. And so it's not uncommon to get an opioid and a skeletal muscle relaxant together. But just note that both of these do suppress the central nervous system. So that is going to affect respiratory functioning and sedation levels. And so we don't want to ever over-sedate a patient or cause them to stop breathing. Also, the skeletal muscle relaxants can cause a seizure risk, especially baclofen, cyclobenzaprine, methocarbamol. You don't want to give these to anyone that has a seizure disorder, or the seizures are going to worsen with these disorders. And also, we don't ever want to stop these abruptly, especially baclofen. And so if someone is taking this regularly and they just stop it, they can have withdrawal symptoms that can cause spasms, hallucinations, or even seizures. And tizanidine can cause really bad high blood pressure if they stop taking it quickly. These will restrict activity, so we don't want patients to drive or operate any heavy machinery. And also, it will affect their decision-making abilities. And so we don't want them to make any important decisions while they're taking this